Medurstand. Understanding Medicine.
I'm Professor Aziz-ur-Rehman, and today we are going to discuss this condition called myeloproliferative disorders. Now, as you can figure out from this term, it is actually a group of disorders, and they all arise from the myeloid tissue, which includes white cell series, platelets, RBCs, and fibrous tissue of the bone marrow. So the other thing which needs your attention is this word, the myeloproliferative. It does not say malignancy or leukemia. Some of them, they are actually leukemias in the true sense, but others are relatively benign condition, at least at certain stage of the disease. So there is abnormal proliferation of any of the components of the bone marrow leading to one of these conditions, and this group is actually dealt with collectively because of the overlap and also because one condition can transform into another one. And out of these four conditions, I will be discussing the chronic myeloid leukemia today. Now, this is the classification, the myeloid series, the proliferative disorders arising from the myeloid tissue would be called myeloproliferative disorders. And first thing is the abnormalities arising from the granulocytes, which is also called white cells. So if there is abnormal growth of white cells, this would lead to chronic myeloid leukemia, also called chronic myelogenous leukemia. And if it arises from the RBCs, it would be called polycythemia rubra vera, or simply polycythemia, to differentiate it from secondary polycythemia, which is much commoner condition. Secondary to chronic hypoxic state, like patient with COPD, they develop secondary polycythemia. And then if the abnormal process starts with the platelets, that would be called essential thrombocytosis. In this case, there will be increased red cell mass, increased RBC count, and in this case, there will be increased platelet count, much more than normal. But the morphology of platelets is mostly normal. And then finally, condition called myelofibrosis. And if there is abnormal growth of fibroid tissue, it will result in myelofibrosis. I will discuss chronic myeloid leukemia in this video, and all these three conditions will be collectively discussed in a separate video. One thing at this point, if you have a case which fits in the diagnosis of chronic myeloid leukemia, there is a possibility that later during the course of the disease, this patient may actually develop feature of any of these, or could actually transform into another condition like myelofibrosis. And it could be reverse also. And another thing is, at any time, there will be predominant chronic myeloid leukemia, but there may also be element of polycythemia, essential thrombocytosis, and little bit of myelofibrosis. So that two things have to be remembered. Number one condition can transform into another one, and second, there is an overlap. And today we are going to discuss this chronic myeloid leukemia, which is one of the most interesting conditions, and there have been a lot of interesting developments in the understanding and the treatment of this condition in the last 2 or 3 decades, and that has really transformed the outcomes of this disease. Chronic myeloid leukemia, let's first discuss the pathophysiology. There is actually, we have 46 sets of chromosomes, and behind most leukemias, there is usually some mutation. Now, in this case, there is a reciprocal translocation between chromosome number 9 and chromosome number 22. Translocation means some portion of chromosome number 9 goes to 22 and some portion of 22 comes to chromosome number 9. This would result in the formation of what is called an oncogene. Oncogene is a cancer forming gene, as you could figure out from the name, and this gene is called BCR-ABL. In the next slide, I would explain what is meant by BCR-ABL. So this gene would stimulate an enzyme called tyrosine kinase. We have many tyrosine kinases in the body. They are mostly responsible for tissue growth, cellular growth. Now, this particular tyrosine kinase is responsible for the growth of white cells. A controlled growth of white cells is very much needed. Of course, without that, we will not have renewal of the cells which die. But in this condition, because of excessive amount of tyrosine kinase, there is abnormal and excessive and uncontrolled growth of white cells, and that leads to formation of chronic myeloid leukemia. So this is actually the pathogenesis, and this has translated, this understanding has translated into better diagnosis and better treatment and the possibility of inducing remission, which was not possible in the past. Now this slide explains it in more detail, and this is chromosome number 9, and this is chromosome number 22. Okay, now as this is normal, this particular section is normal. Chromosome number 9 is much bigger than chromosome number 22, and chromosome number 9 has got this gene called ABL, and this gene is a potentially oncogene. It could result into cancer or leukemia, but it is constantly kept inhibited by the neighboring genes. All right, and this has got chromosome number 9, and this is called breakpoint region, and this is where it could break. So for some reason, we do not exactly understand why this happens. Probably some viral infection that leads to this translocation. This portion goes to this one, and this portion comes to this one. Now because of this BCR-ABL gene is formed. When this ABL is not in this region, as I told you, in this region the neighboring genes keep it inhibited, but when it comes to this new location, there is no gene which would inhibit it, and this gets activated. And since this is attached to the BCR region, and this gene is called BCR-ABL. Now this BCR-ABL gene is an oncogene, and this new chromosome, which is shorter than the actual chromosome number 9, and this is called Philadelphia chromosome. Why do we call it Philadelphia chromosome? Because it was first time described in American city of Philadelphia. Now you know, at that time we did not actually know, the scientists did not know the mechanism behind. All they found was that the chromosome in patient with CML, the chromosome number 9 is different than the normal chromosome 9. So they called it Philadelphia chromosome. And about 85% of the patients with chronic myeloid leukemia, they were found to have this Philadelphia chromosome. And later on, the exact reason and exact pathogenesis and the mechanism of this Philadelphia chromosome was found. So due to this translocation, a new gene, an oncogene, is formed which stimulates tyrosine kinase, and tyrosine kinase stimulate cellular growth, and that stimulated cellular growth results into chronic myeloid leukemia. Since this particular tyrosine kinase is responsible for the growth of white cell, so this process, the chronic myeloid leukemia, will affect predominantly the white cell series. This is the natural course of the disease, and if not treated, there is 20% annual mortality. That is fairly high mortality. That means patient would have on the average 4 to 5 years survival. Now it has got 3 phases. Most diseases, most infection and diseases, they start with acute phase and they could go on to develop chronic phase. But this disease is different. It starts with chronic phase. This is the chronic phase, and then it goes into accelerated phase, and then into what is called blastic phase. So this is the chronic phase. That means patient is minimally symptomatic, and in fact patient may not have any symptoms at all, and diagnosis may be made just by incidental blood examination. Blood is tested for some other reason and gross leukocytosis is detected, and then on further testing it is found that patient has got chronic myeloid leukemia. Patient may not have any symptoms at all. Patient is likely to have some signs like splenomegaly but may not have any symptom. Disease is very slow, smoldering, and this is the chronic phase. Anytime, mostly because of an additional mutation. I have already explained a mutation which causes chronic myeloid leukemia, and it is generally believed that some unlucky people, they would develop another mutation and that would accelerate the disease process. A slow smoldering disease will become active, and this is called accelerated phase. There is further increase in the white cell count, and there are more and more blast cells and premature cells present in the bone marrow as well as in the peripheral blood. And patient is likely to develop symptoms here like fever because of the superadded infection, maybe body pains, maybe pallor, maybe dyspnea, maybe pain in the left hypochondrium. So patient is likely to become symptomatic at this stage, and our treatment is to keep the patient in the chronic phase and actually to reverse it. So after accelerated phase, because of another mutation, it could end up in acute blastic crisis. Now this is really very serious phase. Those patients who go into acute blastic crisis, they have very high chances of death. In fact, these patients, they might not actually respond to the chemotherapy also, and the chemotherapy would be very different. Chemotherapy which is given in the chronic phase would be very different than the treatment which is offered in the acute blastic crisis. So aim of the treatment is to prevent this accelerated phase and acute blastic crisis, and aim is actually to achieve a remission. So this is the natural course. This would be, with this you will see in patients who are not treated with newer anti-malignant drugs. Clinical features: patient may be asymptomatic or the symptoms may be very subtle. Often physician miss those symptoms as suggestive. They could be just non-specific symptom, and it could be incidental diagnosis. Patient had blood tests for some other reason. Like for example, patient was planning some surgery or pregnancy or something like that, and blood was tested and they found that there was leukocytosis, and finally the diagnosis of chronic myeloid leukemia was made. And then patient may have pallor. In bone marrow disorder, if there is a proliferative disorder arising from one series of cells, that series of cells would increase in number, but other series of cells may be actually suppressed for various reasons. The simplest reason is that the more bone marrow will be occupied by the malignant tissue, and the normal healthy bone marrow will reduce in size. So because of reduced RBC precursors, RBCs will be reduced in number and there will be anemia, and that will translate into pallor. There may be fever because these patients, they have many white cells, but these white cells may not be immunologically competent, and these patients may develop superadded infection and they may present with a fever. And fever could be due to some other reason, or fever could be due to leukemia itself, or fever could be due to superadded bacterial or viral infection. And night sweats, and this is one feature: low grade fever with evening rise or night sweat. This may mimic actually tuberculosis also. Then left hypochondriac pain and heaviness. One feature of chronic myeloid leukemia is splenomegaly, and there could be actually massive splenomegaly. Spleen may be 5 times, 6 times, even 10 times bigger than normal. So it could grow up and then come down into the abdomen, and sometimes it can go up to the right, like fossa. It could be that big. So that heavy spleen may cause heaviness in the left hypochondrium, or there could be actually secondary infarctions in the spleen because of leukocytosis. So there could be severe pain in left hypochondrium also. Then there may be what is called hyperviscosity syndrome. That means, that is the other name of the same is leukostatic manifestation. When there is increased white cell count, normally the count is 4 to 11, and in chronic myeloid leukemia the count could go into 100,000, maybe 200,000, maybe 300,000. So that high count is going to make blood very thick and difficult to flow, and that could actually clog up some small vessel, and patient may develop multiple microinfarction, maybe in the eye, maybe in the brain, maybe in the skin, maybe in the fingers. So this could be a hyperviscosity syndrome. Patient may develop pulmonary edema-like condition, renal failure-like condition. So this is all because of hyperviscosity. So these were the symptoms, and none of them is very specific. Any physician, if somebody has pallor and if on examination there is splenomegaly, I think any physician would suspect CML and would do the first line of investigation is peripheral blood examination, and if that shows leukocytosis, then the definitive diagnosis will be bone marrow examination. Now let me just explain this process. If you have pallor and massive splenomegaly, you must suspect chronic myeloid leukemia. And then the first test is blood complete examination, or what we call CBC. And the CBC is done by machine, and machine is actually very, very efficient in counting, and it will give you the exact number of cells. And the newer machines actually give you the differential also, and it will also indicate if any abnormal cells are present. So very high TLC. Normally, whenever somebody has high TLC, the first thing which comes to our mind is some infection. But in fact, in infections, TLC is usually like in maybe 20,000, 25,000, maybe 30,000, but usually not beyond that unless it is severe acute infection. But in this case, the count may be in hundreds and thousands. And there may be presence of immature forms of WBC. In acute infection, you also have relatively younger cells, but they are not abnormal. There may be single-lobed cells, there may be band cells, there may be shift to left. But in cases of chronic myeloid leukemia, you will have many abnormal premature cells belonging to white cell series, like presence of myelocytes, promyelocytes, metamyelocytes. These cells and the blast cells will be present in the peripheral blood. And there is maybe also reduced leukocytic alkaline phosphatase. Now this is the enzyme which also is deficient in those patients who have Philadelphia chromosome. In 85% patients with CML would have reduced leukocytic alkaline phosphatase. Now, on the basis of this, the diagnosis of chronic myeloid leukemia is very likely, but normally we do bone marrow biopsy also, because bone marrow biopsy gives us a better picture and gives us a definite and final diagnosis, because there are actually variants of leukemias. So I think only after bone marrow examination, the histopathologist gets a chance to examine all the bone marrow cells and is able to make a definitive diagnosis. There are two types of bone marrow biopsies, aspiration biopsy and trephine biopsy. I think in this case, just simple aspiration biopsy would be sufficient, because aspiration biopsy, you just collect the sample of bone marrow, whereas in trephine biopsy, you take out a portion of bone along with bone marrow. I believe trephine biopsy should still give you a better picture, but simple aspiration biopsy is relatively easy on patients. So the first line of investigation may be aspiration biopsy. And then on that biopsy specimen and also in the peripheral blood, you could determine the presence of this BCR-ABL gene by PCR technique. And you know PCR is polymerase chain reaction. Any enzyme, any gene, any DNA, any RNA, we can multiply many times with this PCR technology till it becomes detectable. So this is very easy test. This can be done on the peripheral blood and this can also be done on the bone marrow sample. Then cytogenetics means the examination of cells and the under electron microscope and determination of the Philadelphia chromosome. That would be cytogenetics. So that is going one step further. Do we decide that this patient has got chronic myeloid leukemia and that type of chronic myeloid leukemia which has got positive Philadelphia chromosome and those abnormal cells. And then this is called FISH. This FISH is short of fluorescence in situ hybridization. This would also determine the presence of BCR-ABL gene present in the chromosome in the blood, and this is a relatively easier test as compared to cytogenetics. So this is replacing cytogenetics, but both are available and both can be done, and any of the two can be done. So if you go this way, I think you will have exactly complete and accurate diagnosis. This is the peripheral smear, and if you can see, there are too many white cells. This whole field is flooded with white cells, and this is abnormal cells, maybe blast cells, and these are different types of cells. I wouldn't know for sure, but these are precursors of white cells. So this should give you a clue to the diagnosis of chronic myeloid leukemia. But one thing is sure, that these are white cells and they belong to myeloid series. This is Philadelphia chromosome by FISH technique, and these fluorescent, you know, these things, they are fluorescent, and there is a special technique, and with that technique, if there is any chromosome which contains that BCR-ABL gene, and that BCR-ABL gene will become fluorescent. They use, I think they tag monoclonal antibodies against BCR-ABL gene, and they tag it with and then they put it here, and if there is BCR-ABL gene, and that will combine with it and then will show fluorescence. Treatment. Now the treatment, first of all, what is the aim of the treatment? And normally the aim of the treatment is to achieve cure. In most conditions, that is at least what we hope for, but in this condition, a cure may not be the first aim. The first aim is to achieve remission, and of course we would like to achieve cure also. In oncology, if somebody achieves remission and remains in remission for 10 years, it is considered to be cured. Now, what are different types of remissions? First remission is hematological. Now, if somebody had abnormal TLC, splenomegaly, lymphadenopathy, pallor, abnormal bone marrow, if all of them disappear after treatment, that would mean that patient has achieved hematological remission. So all hematological abnormalities, all symptoms, all clinical signs, and all hematological abnormalities in the peripheral blood and in the bone marrow have disappeared. That means patient has got hematological remission. That is something great. So that means we have achieved first step. If somebody achieves cytogenetic remission, that would be another step. That means those abnormal cells in the blood and in the bone marrow which carry those Philadelphia chromosome, if all those cells they disappear, they become undetectable, that would mean patient has got another level of remission, that is cytogenetic remission. And ultimate is molecular remission. That means with PCR you will not be able to detect this abnormal BCR-ABL gene in the bone marrow or in the blood. So I think the most lucky person would achieve all three, the triple remission. And if that is the case, we can definitely hope for long-term remission and possibly cure. And then once we achieve the remission, then we offer some treatment to maintain remission. If this is not done, there is a possibility that the disease might come back and there could be actually relapse. So after achieving remission, patient usually stays on some maintenance treatment, the treatment may be the same which we use in the remission phase, or it may be different. But some treatment is usually continued even if somebody has clinically recovered and has achieved triple remission. Now let's come to the treatment. First of all, the traditional drug, this is not used these days, at least as a preferred choice, but this is a historical treatment, and the aim of using busulfan was only to keep the count in a safe limit. It was not capable of curing the disease. It was not capable of achieving remission. So with the use of busulfan, we would want to reduce TLC count, and we want to bring it below 20,000. And then typically we will stop busulfan and will continue to monitor, and then that count will still come down, and once it comes below 10,000 we will start busulfan again. The aim used to be to keep TLC count within 10,000 and 20,000. Then came in hydroxyurea and interferon. They were slightly better than busulfan, or at least as adjuvant therapy, but they were also not capable of achieving remission. This is all historical, but then after the better understanding of the disease, the historical treatment came in, which actually revolutionized the outcome of the disease. And this medicine was called imatinib. Imatinib is tyrosine kinase inhibitor, precisely BCR-ABL tyrosine kinase inhibitor. This is called Gleevec. This is the first line treatment, and with the use of Gleevec, because it actually addresses the actual disease process, it destroys the enzyme which is responsible for abnormal growth, so patient achieves the remission. There are some cases who might not respond to this first line. They may be treated with second line. This nilotinib, Tasigna, and other second line drugs may be used. So I think this of course takes us beyond the domain of internal medicine. Usually a qualified oncologist or hematologist oncologist would treat these patients, and typically starting with imatinib, going on to the other tyrosine kinase inhibitors. Now, if somebody is lucky to achieve triple remission, that patient will be maintained on this this drug, tyrosine kinase inhibitor, for life. But those who do not respond to begin with, or who did respond but develop relapse, and they may be considered bone marrow and or stem cell transplantation. In this, the sample, the bone marrow, is taken from the healthy person, compatible the blood group compatible, HLA compatible person, and bone marrow is taken from the healthy person, and then that is transfused into the person who has this disease. And this is of course needs a lot of technical detail which is beyond my scope, and you just understand that bone marrow transplantation is the final option in these patients. Now, stem cell transplantation has become even more attractive. In this, patient is given growth factor, and the donor is given growth factor, and then you don't have to do the bone marrow puncture to take sample. Then the peripheral blood is collected, and that is transfused into the recipient. So that has improved the chances of transplantation, and this is considered to be curative. Of course, it would require a lot of resources. You need a facility where all this is possible, and you need a healthy donor, and it is an expensive treatment. But those patients who undergo bone marrow transplantation or stem cell transplantation, and they may be considered cured because their own bone marrow is destroyed with radiation, and this new bone marrow, which is without that mutation, which does not have that malignant potential, that is transplanted, and patient can really look forward to a long-term survival. Supportive therapy, all these patients, they need supportive therapy. If they develop infection, they would require treatment with antibiotics, and if they develop anemia, they might require blood transfusion. So that kind of thing, and the supportive therapy is always needed. Those who undergo bone marrow transplantation, stem cell transplantation, they would also require some kind of treatment to keep this graft going and to discourage any rejection, graft rejection. This is the treatment algorithm. I have already explained to you the treatment, but this is another slide showing you the algorithm. First of all, we make a diagnosis based on peripheral blood examination, based on bone marrow examination, based on FISH, based on cytogenetics, based on BCR-ABL gene PCR. And the first line of treatment is imatinib, which is tyrosine kinase inhibitor. If there is a response, good response, then of course we continue. But if there is no response to first line tyrosine kinase inhibitor, and then we consider second line tyrosine kinase inhibitor like Tasigna, and then we hope that patient respond to second line tyrosine kinase inhibitor, and those who respond, that drug is continued. Those unfortunate people who do not respond, then of course bone marrow transplantation or stem cell transplantation may be considered. So this is the treatment outline. The prognosis, generally speaking, it is slowly progressive disease if it remains in the chronic phase, but unluckily many patients would go into accelerated phase, then into acute blastic crisis. There could be rapid downhill, and without treatment the prognosis, average life expectancy is 4 to 5 years. Previously it used to be fatal in 100% cases, and there used to be 20% annual mortality. With imatinib and bone marrow transplantation, prognosis has improved tremendously. Now we can hope for long-term survival and complete remission and complete cure. In these patients, there is a possibility of development of another malignancy or another disorder of myeloproliferative disorder group, but at least many would live a very, very long and healthy life. So that was it. I really thank you for listening to this video, and this was about chronic myeloid leukemia. I hope I was able to give you some insight into this interesting disease, how it is diagnosed and how it is treated. In my next video, I will cover other 3 conditions, myelofibrosis, essential thrombocytosis, and polycythemia vera, which are other types of myeloproliferative disorder. Thank you. This has been Professor Aziz-ur-Rehman from Medurstand. I really look forward to see you in my next video. Thank you.